Marom for her time and help in this presentation. Today I'm going to present to you a case of 45-year-old man with medical history of ischemic heart disease, diabetes, renal failure, and anemia. He presented to our ER complaining of left lower chest pain for the last 2 months, cough, pain not related to breathing, swelling in the left lower chest. He denies fever, chills, or abdominal pain. On his physical examination, he had normal vital signs, decreased air entry into the left lower lobe, left lower thoracic subcutaneous swelling, no abdominal tenderness. His lab workout was significant for leukocytosis, anemia, and elevated liver and function tests. His ECG was normal. On his frontal chest radiography, there is we saw an opacity overlying the left lower hemithorax. When we look closely, it's obliterating the left cardiac border, when we thought that there is a problem or abnormality in the lingula. And you can see here also pleural thickening. We didn't know if it's because of pleural thickening or pleural effusion. And here also the fullness in the left lower chest wall. For continuing evaluation of the left lower chest wall swelling, the patient underwent ultrasound. In the ultrasound, you can see here the skin, superficial fascia, and the collection between the muscle fibers with fat infiltrations over the rib. So we continued investigation with chest CT. On the lung window, axial lung window, we saw bilateral pleural effusion with a consolidation in the lingula, and interestingly, there is air in the left chest border, chest wall. And the soft tissue window, confirming the findings, we saw bilateral pleural effusion with consolidation in the lingula, and the adjacent chest wall, there was a complex collection with fat infiltration around it. So, considering our patient came with swelling in his left chest, we put this differential diagnosis as first traumatic penetrating trauma or iatrogenic needle aspiration or chest wall surgeries, transdiaphragmatic spread of intra or infra-abdominal infections or collections, malignancy as in chest wall sarcomas, pleural base masses as in mesotheliomas, and also the infections as in pyemia necessitans and pneumonias that can cross chest wall. Going back to our patients, he underwent debridement surgeries. Cultures were taken from the area and covered with broad-spectrum antibiotics. So interestingly, at the time of the surgery, the surgeons revealed a tract, or they detected a tract between the subcutaneous correction into the thoracic cavity. So going back to our differential diagnosis, the patient didn't have any prior trauma, denies trauma. He didn't underwent any surgical manipulations. The CT didn't show any diaphragmatic spread of abdominal, infra-abdominal correction or infections, and there were no signs of malignancy, which leaves us with the infection causes as in pyemia necessitans and pneumonia. So I want to talk about the infection crossing chest walls, which is extension of pulmonary or pleural infections out of the thoracic cavity and into the neighboring chest wall and the surrounding soft tissues. The pathology, it's either occurs due to virulence of the organism. It may be facilitated by previous thoracic surgery or trauma. It occurs commonly to the subcutaneous tissue of the chest wall. It can also spread involving other sites, and the resultant of it is abscess, rupture through the skin. So the most common cause of those infections that can cross the chest wall is Mycobacterium tuberculosis, which we can see it in a patient population with this organism, or recent travelers, or people who are get in contact with patient with this organism. And the bacterial causes as actinomycosis, it's considered the second most common cause. Fusobacterium, those bacteria we should consider them in patients with bad dentations, alcoholic patients, and patients with mildly immunocompromised. We also shouldn't forget the blastomycosis, which is found mainly in the South American areas, and the invasive fungal infections as aspergillosis and mucormycosis, which we can see them in severely immunocompromised patients and patients who have hematological malignancies and post-bone marrow transplantation. So going back to our patient, the cultures that were taken at the time of the surgery revealed infection with Schlagia exigua, which is a gram-positive staining, strictly anaerobic, non-motile, non-sporin-forming, rod-shaped organism, most found in the oral canal and the intestines of human beings. It's a kingdom of bacteria and phylum of Actinobacteria. So I searched the literature about this organism. I found little data in the literature talking about this infection. When there was a study in 2005, between 2005 and 2007 in the States, they detected, they took cultures from 400 patients from infected sites. They found 11 of them with this specific organism, and 6 of this organism are from oral cavity, and 2 case reports about cavernous sinus thrombosis with this organism and meningitis in a patient with rectal cancer. So, as a take-home message, I don't want to talk about this specific organism. I want to talk about a patient with susceptible or chronic aspiration. Chronic aspiration tend to have an indolent course of more than days to weeks. The symptoms may be fluid, and those patients with chronic aspiration tend to have a very subclinical symptoms. And we should also think about every patient with diabetes mellitus or renal failure who are mildly immunocompromised, who can present with late complications such as weight loss, anemia, lung abscesses, or empyema. We should always think about pneumonia and think about anaerobes.